Good evening, everyone, and welcome to the Facial Pain Association webinar series. My name is Allie Kubik, and I am a board member, but I'm also a facial pain patient. So tonight's webinar, we have Dr. Jeffrey Brown, who's chair of our medical advisory board, who will be interviewing Dr. Cohen, who also serves on the medical advisory board.
So good evening, all. We're going to focus on medicine today. We're not going to focus on surgery. We're not going to focus on how to avoid surgery, but we're going to focus on what are the best medicines and why do they work. And I'll remind you that if something goes by that you didn't catch, we're going to post this interview on the website of the Facial Pain Organization within a few days, and you can review it. And that's fpa-support.org. And then if you need more information, on November 2nd and 3rd, we're having our biannual national meeting at the University of California, San Diego, in San Diego, California. And we hope that you'll be able to join us there for 2 days to hear from physicians, talk with physicians individually, and other patients. So my first question for Dr. Cohen is, why are medicines for neuropathic facial pain different from all other medicines? What's the difference?
Well, first of all, let me say thanks, Dr. Brown and the Facial Pain Association for having me participate. This is a terrific opportunity to learn about medications and medical treatments, and I'm certainly glad to help out. So to get to your question, why are these medicines different? Well, these medicines are different because the pain is different as well. There are different types of pain. There's the type of pain that you get when you stub your toe or you scrape your knee, or even pain from arthritis. And then that's sort of nociceptive pain. And then there's the pain of diseases like trigeminal neuralgia and other facial pains, which are considered to be neuropathic pain, that is generated from injury to nerves and structures related to nerves themselves. So it does require different types of medication to treat. I'm sure we have a whole host of people out there listening right now who are all too familiar with these issues that, when they have facial pain or trigeminal neuralgia attacks, if they take medicines like Tylenol or Advil, it's unlikely to help much at all. And if any, it's almost like taking nothing. So it's been studied and it's been understood that there are a host of different types of medications that will treat neuropathic pain, some better than others. And they have different mechanisms of action about where they attack the pain and by what mechanism that they attack the pain.
Clarify what you mean by neuropathic as opposed to this other kind of pain, nociceptive. Explain a little bit more. What's neuropathic mean?
Right, so neuropathic pain refers to pain that is primarily generated by nerves or the brain or injury to the nerve roots or the spinal cord or peripheral nerves in your arms and legs, nerves in your face. And obviously the trigeminal nerve is one of the primary nerves that innervates sensory function and some motor function of cranial nerves and in the face itself. So the way nerves work is that they generate action potentials and pulses of electricity, and they travel along defined pathways. And so when you have pain caused by structures such as that, mechanisms such as that, you need medications that are going to work on those structures. And so medicines like Tylenol or Advil, or with other medicines like Advil, that are called non-steroidal anti-inflammatory drugs, are great drugs for other types of pain, but don't really touch this.
Why not? Why don't they work? What don't they do?
Well, they don't affect the transmission of pain signals in the nervous system. They can reduce inflammation.
So they reduce inflammation. So is trigeminal neuropathic pain from inflammation?
Usually not per se. I mean, it's certainly in its pure form, as many people in the group know. The classic trigeminal neuralgia, that sharp, shooting, lancinating pain, those sharp attacks, knife-like attacks that typically are seconds but can repeat for several minutes. Those are pulses generated by nerve structures themselves, as opposed to you fall and you break a hip and there's all kinds of bones that are fractured, or that there's a secondary inflammatory and swelling situation. So, trigeminal neuralgia, we believe, at least in its classic form, is caused by vascular structures, an artery, sometimes a vein, that is pushing and pulsing and compressing the trigeminal nerve.
Okay. So what do you do to treat this neuropathic pain? What kind of medicine do you use?
Right. So the good news is that there are many medications, and perhaps the not so good news is that they all don't work equally, and they all don't work in every person. So let's start on the positive side, because there is a lot of positive. And typically, first line of defense in terms of neuropathic pain medicines are medicines that have also been used successfully to treat epileptic seizures. So some of the classical ones, or the very first one, well, I don't know, not the very first, but the very first in, let's say, modern era would be carbamazepine, or known as Tegretol, and there are many different forms of that at this point. And Tegretol, or carbamazepine, is what they call a sodium channel blocker. So it blocks sodium channel receptors, and so it inhibits those structures from having excessive electrical activity. And at least initially, in about 70 to 80% of people that take this medicine, it can be very effective. A drug like carbamazepine is a popular one as a first drug to try. Go ahead.
Have studies been done? Has the FDA approved that it's the right drug to use?
It's one of the better studied drugs for trigeminal neuralgia. It is the only FDA-approved medicine for trigeminal neuralgia, and that approval came in way back in 1974. Actually, it's interesting because even though more people associate it as being an anti-seizure drug now, its first indication was for trigeminal neuralgia. It's got a long history. Even though it was first approved in the U.S. in '74, it was used in Europe clinically way back in 1960, and so we have a large experience with it. In general, it's a fairly safe drug, meaning that many people do well with it.
Bad things can happen.
But bad things can happen with everything, and so. But before we get into the bad things, there are a lot of people who do well with it, at least initially, meaning the first couple of years. And what do I mean by doing well? Significant reduction in their pain. And many people can tolerate it too, meaning that they're not having the bad things happen. But obviously, all drugs. And so using a drug like that, or any other drug, is really a balance between how to use it properly, how to get it into the system, how to keep it at an even level, and how to minimize, using the right dose, how to minimize the chances of bad things happening or side effects. And so what are the main side effects that people experience? There are things like dizziness, double vision, imbalance. Those are pretty common, and those are dose related. That means that the higher the dose, the more likely those things are going to happen. Then there are some more, let's say, interesting side effects. It can lower the amount of sodium in your blood, and a little bit of lowering is okay, but a lot is not okay, and you can get very sick from that as well. It can also affect the liver. So sometimes people who have very sensitive livers or are on other medications that are metabolized by the liver may have additional problems with the drug. So again, no free lunch, but on the other hand, do very well. It's a little tricky to use.
Is it like an antibiotic? Is there a right dose and blood level and all that?
Well, I mean, there are recommended doses for the use of it, and but it's a little tricky to use in the beginning. And I say that because on the one hand, if you've got horrible trigeminal neuralgia, let's say this is the beginning of this terrible illness, and you go to the doctor and the doctor is smart enough to figure out that that's what you have and say, oh, I know that Tegretol is going to work for this, which is a good thought. But because sometimes what we see is if the doctor isn't comfortable or doesn't have a lot of experience in using the drug, in the interest of trying to get rid of your pain, they may advance far too quickly. So you see sometimes where it's the right choice of a medicine, but maybe not the right dose. What is the right dose? The right dose is the right one for you. But in general, you like to start it at a relatively low dose, once a day, twice a day, and then building up in its basic form. You build it up to 3 times a day, and you build it up over weeks. If you go too fast, and sometimes people go too fast because they're trying to get rid of the pain, you can get very sick very quickly. And why is that? It has a very, very, very special property, different from a lot of other drugs. So the molecule of Tegretol can induce its own metabolism in the liver. It affects the enzymes and it sort of revs them up. So in the beginning, it takes a long time for a person to clear a dose of Tegretol, maybe as much as 12 to 24 hours. Fast forward to someone who's taking it at the proper dose in 3 weeks, the elimination half-life, or how long it takes to get rid of the drug from the system, can drop to 6 to 8 hours. So if someone just looks up on the internet or looks in the book and says, okay, I need to give this person 600 milligrams, if you start that day 1, there's a high likelihood that by day 3, you'll feel very sick from the side effects. If you start it on a much lower dose and build it up over several weeks, it's much less likely you'll run into trouble. So we have seen patients, unfortunately, over the years, they've already been through a couple of doctors, a couple of drugs, and you ask them, did you try Tegretol? And they say, oh no, that made me really sick, I threw up. Well, it's possible. But then if you are able to get through a history, you often find out that it was started too quickly and that there is an opportunity to reuse it. There are cousins of Tegretol now. There's another one called oxcarbazepine or trileptal, and there are several forms of that at this point. Thought to be a little bit kinder and gentler in terms of side effects. The efficacy or the ability to reduce a trigeminal neuralgia pain is probably close to the same thing, and some people tolerate it a little bit better. The doses tend to be a little bit higher, but that doesn't mean that you get sicker from it. So some people who didn't do so well with Tegretol may do well with trileptal, and it doesn't seem to have as much of an effect on the liver as Tegretol. It does seem to affect the sodium level in the blood, so that's something that has to be monitored. But it seems like a reasonable option, and there are generic forms of it now, so it's not so expensive. Go ahead.
You said expensive. What is there something expensive about the trileptal compared to the Tegretol?
At this point, no. I think obviously when a new drug comes to market, they're usually priced higher than the old drug. And a lot of reasons for that, right or wrong. But at this point in time, there really shouldn't be much of a difference. And again, it's available in a generic form. I think you also asked a little bit about blood tests and things like that. So certainly for Tegretol, there is an established blood test. So the doctor can check, in let's say 2, 3, 4 weeks after you start it to see if there is a reasonable level in your blood. I say reasonable as opposed to correct or whatever, because I think, again, when it comes to facial pain, I think it's a very individualized situation. You know, when it comes to seizures, I think we're closer to using the words correct for a certain level. You want it between a certain range. When it comes to facial pain, I think it's those guidelines, or the lowest amount that you want versus the highest amount you want, is not so clear. I think you really have to work on, you know, is the person doing well with that dose? Is it affecting anything negatively in the blood? And then work with it like that. For a drug like Trileptal, you probably can get a drug level. It's probably not very useful. And at least in the beginning, we used to see a problem where somebody would be put on Trileptal, and let's say they'd have breakthrough pain. They'd go to the emergency room because they were looking for help. The doctor would say, and ask them what they're taking. They might say Trileptal, they might say the generic form, and they wouldn't necessarily hear it, and they would think they're on Tegretol. They'd measure a drug level. The drug level would be near zero, and they'd tell the person to double the dose, which would be an error, but it did happen sometimes. And then the person would get really sick in a couple of days. So that happens less frequently now. But I think the role of blood work is important when you're taking these kinds of drugs, because, again, helps to keep you safe. In other words, it helps to check your sodium level, helps to check your liver to make sure that there's no harm to it. But they remain first-line treatments. Now, there's one more drug in the family now, carbazepine. It's yet another metabolite of the other two drugs, not really used as much in facial pain, but, you know, might be an option for some people. There's no generic for that yet.
What's this last drug called?
slightly carbazepine. So it's a cousin of the other two drugs. Yeah, we're not using much of it for here. It may not work as well, but again, when things don't work, you know, you need to be creative and you need to try different things.
Let's talk about not working. So someone has stabbing pain in their face. Their doctor starts them on Tegretol. They take more Tegretol. They take a little bit more. When should they decide that a little bit more isn't going to do it and they need to switch? Is there some point that makes sense? It didn't work.
Yeah, no, I think you have to keep measuring that pain. You know, hopefully they're asking you on a facial pain scale, or at least on a scale of 1 to 10, how bad your pain is. If you're taking, you know, what anybody would consider to be higher doses, and again, I hesitate to throw out numbers because it can be very individualized. But if you're at the point where, you know, you're getting only a very small reduction in pain after you take the medication, and you're walking around feeling woozy and you can't read because you have double vision, or your balance is off, or you even fall or almost fall, you know, you've probably reached the limit of that drug. At that point,
it's when the side effect becomes excessive that you stop that drug. And can you just stop it, by the way? Say, okay, I'm not going to work on that one. Let's go to another one, or do you have to do anything to get off the drug?
Yeah, that's also important. I think it depends. You know, if you were unfortunate to develop an extremely serious side effect, maybe a bad rash all over the body, you know, you're probably going to want to stop that quickly. If it's a situation where it's a side effect that we would call dose related, meaning that the higher the dose, you know, the more the side effect, like the ones I just mentioned, your balance is off, you've got double vision, and so on, I would probably go down slower than that, you know, to avoid any potential, you know, withdrawal situations. So if it's a so-called idiopathic or non-dose related side effect, like a severe rash, you stop it immediately. If it's something that is dose related, like balance and double vision, and cognitive, or just not thinking clearly, I think you come down more slowly. Also, because you may realize that even though it wasn't completely controlling the pain, it was probably doing a little bit, and a little bit is sometimes better than nothing.
So you got Tegretol, Trileptal as your second line drug. What's next?
Well, then there's a whole host of things, and you know, there was for those interested, and you can get it on the internet, there is a 2019 review of medical treatments and some surgical treatments of trigeminal neuralgia by the European Neurological Society. You can just type that in Google, look for medical, review of medical treatments, whatever. And they go through it very carefully. And while we have a fair amount of studies, we don't have a lot of great studies. And that's important because then we're not necessarily making decisions based upon, what at least up until recently has been the gold standard for evaluating medications, randomized, double-blind, placebo-controlled studies. We don't have a lot of that in trigeminal neuralgia, even though we know this has been missing for a long time. We do have some studies that compare, small studies that compare people who take these drugs versus not taking these drugs, and a couple of head-to-head studies of drug 1 versus drug 2. So it's just a way of saying that there's a lot of clinical judgment in terms of what's next. Well, what's next? People tried other anti-seizure medicines called gabapentin or Neurontin, or Lyrica or pregabalin. Those are different types of anti-seizure drugs, which do have a lot of efficacy and can be successful in many people for neuropathic pain. They may not be as effective, but in a particular individual, they may be better than Tegretol.
So if the drug isn't working, like Tegretol, is it best to get off the drug and start another one, or do you add one on top of it?
Yeah, my approach is an individualized approach. If the reason that you're coming off of it is that you just can't tolerate it because it makes you sick, then you're probably going to come off of that. If it's a situation where you've gotten to a reasonable level, you've had some response in terms of reduction of pain, but you're not really, you're functioning okay in terms of side effects, you might consider adding a second drug, and a drug like gabapentin is reasonable. Other anti-seizure drugs for which we have some data would be a drug called lamotrigine, another anti-seizure drug. And then there's no shortage of second and third line drugs then. We can go through a very long list. By 2019, there are probably, 30 plus anti-seizure drugs on the market. They all don't work for neuropathic pain, but a lot of them have some. There's been somebody's reported. I've had personal experience with patients where, they've already come to me, had really good trials of trying, the first 4 or 5 drugs, and we try something else. There is always something to try in this realm. There are other what I would call neuropathic pain drugs that are not anti-seizure drugs. One of the older ones that still can be used is a drug called baclofen, which can be it was used for to reducing spasms. And there are a couple of small studies showing that it can work for neuropathic facial pain or trigeminal neuralgia. So, I think it depends. There are people who, if you're really sick on a drug, you're off that first drug, you're on to drug number 2, you may switch to 3 and so on. We don't really have a lot of data on combinations except for things like Tegretol plus lamotrigine or Tegretol plus lamictal. I'm mixing the generic and the brand names because some people may not recognize them. So combinations are not unreasonable.
Are these drugs like antibiotics? Are they going to cure the problem?
Unfortunately, no. We know that, for a lot of people, trigeminal neuralgia can be episodic. The attacks are episodic, and then sometimes people can go into remission. So if your pain is going to stop, it's probably because you're going into remission most of the time, or it's being held down by the drug. But yeah, it would be great if it were like infections where, I get something, I get pneumonia and I take an antibiotic and I get better and I'm done with it. You're usually not done with it, although, we've all experienced people, and maybe some in our audience, that have had remissions for months, a year, sometimes even more, and they come off these medications. So that's a tricky one. It's really a tricky one to know, gee, when my pain has stopped and it's 3 months into this, is it because I'm in remission, or is it because it's the medication? But, one way to possibly look at that is, let's say it's 3 months better, your pain is virtually zero, you can try to come down a little bit on the medication. And if the pain comes back, well, then you know you really still need it.
Do you need to make sure the doctor's in control, or do people have any leeway on their own to do this? Is there something they can do that's dangerous if they quote, play with the medicine?
Yeah, those are great questions, Jeff. You know, there's a reason that these drugs are a prescription and not over the counter. Right? In general, I think things like, not that you can't get into trouble with over the counter medications, but you know, they're over the counter because the safety profile is pretty good, and you know, people usually don't get into a lot of trouble by taking extra doses if it's a rare event. With these drugs, obviously, there's all patients. I mean, people don't want to be in pain. We don't want you to be in pain. So there's a tendency to say, okay, the doctor told me to take 2 pills twice a day. It's on a weekend, and you know what? I'm breaking through. I just took the 2 pills. As I break through, I'll just take another 2, and then it works. And then you start changing the dose. I think that's a discussion you need to have with your treating doctor from the get-go. You know, when the doctor prescribes it, please ask him or her, okay, this is the dose you're telling me, but what happens if it's Saturday night at midnight and I can't get a hold of you and I'm really in bad pain? Am I allowed to take another pill? And you know, I think so the answer will be sometimes yes, sometimes no, depending upon the medication. So I would caution people to be their own decision makers about how much is okay. I know there's a lot of information out there on the web, so you can look things up and say, you know, I need to look out for this, that, and the other thing. But there is an art to prescribing these medicines. And if you've got a doctor who's very versed in it and experienced, you know, they have a lot of experience in knowing, you know, how far you can go and what's okay, what's not okay. I think that if you do increase it because you're desperate and you're having a bad night, that you let the doctor know the next day, you know, to make sure that that's a safe thing to do.
Along those lines, there's been a lot of press about drugs and bad drugs. Are these drugs addictive? Are they addictive?
Well, in general, the seizure drugs are not addictive. They're not. There's no evidence for that. I mean, there's a couple of them that are not seizure drugs that are not facial pain drugs that are scheduled, meaning that they have some potential, but not the Tegratols and the Neurontins and things like that. At least that's a good thing.
Well, let's talk a little bit about these addictive drugs, opioids. People take pain, do they get better? Are they okay? Is it not okay?
Yeah, well, again, when people have severe pain and they don't know what to do, and the first and second line and third line drugs are not doing what they're supposed to be doing, you know, people do, and a significant number of people end up on some form of opioids. I think everybody on this line is aware of what's being reported online I would say newspapers, but there aren't any newspapers really. It's all online news, and on television and internet about the opioid crisis that we're in. So you know, you got to be careful with them. You know, on the one hand, there's no question that there's a couple of people here and there that say that it's the only thing that works. I would put a lot of caution out there. There's not a lot of evidence in terms of studies, if any, that it's effective in trigeminal neuralgia and other neuropathic pain conditions. So I'll bet there's a significant minority of people that are listening right now that are using some form of it. Personally, it's not something I ever prescribe for any of my neuropathic pain patients. So again, you know, there are so many, you know, we're seeing all this unfortunate stuff about opioid-related deaths daily in the United States. Is something to be, I'm not saying you should never use these drugs, but very carefully and be sure that you really need them. You know, they do induce, they do have addictive potentials. They do make a certain number of people, you know, feel quote high, so to speak. And so sometimes people can mistake that with the relief of pain. There is a role for them, but it's not usually trigeminal neuralgia.
Let me back up a little bit. A while ago, you mentioned with Tegretol and Trileptal, it can lower sodium. Why is that bad? Well, when is it really bad?
Right, and like everything else, it depends how much. So there is a normal amount that's in the blood system that's needed for maintenance of all kinds of body functions, whether it's nerve functions or heart functions and things like that. So if it drops too low, things like kidneys don't work great, hearts don't work great, and certainly the brain doesn't work great. If it drops severely low, people can actually have cognitive changes, and in its worst form, they can go into coma. So, and the other thing that's probably worth mentioning about that is some people think, oh, okay, if I take more Tegretol, my sodium goes down, I'll just take more salt, and it actually doesn't work that way. It's the treatment for that is actually restricting fluids, not adding salt. Adding salt really just gets thrown away by the kidneys. So it's worth knowing. It's not uncommon to have a little bit of low sodium when you take Tegretol, but it's not that common to drop it to severe levels.
How often should they check to make sure that it's not dropping too soon?
Well, if you start a drug, I probably would check within 3 to 4 weeks. If you're on a maintenance amount where you're on the same amount for a long time, probably twice a year is probably sufficient. Or if you're on a maintenance dose and then the doctor says you need to increase it, by a couple of pills a day or a couple of 100 milligrams, probably 3-4 weeks after that, you would recheck that as well.
Any new drugs coming around? Miracle drug?
Well, there's always something new somewhere, right? Some people may know because I think I'm not sure it's been on the FDA website or whatever, but there is an interesting drug in development. It's been a very slow development. There's another sodium channel drug which seems to be different from Tegretol and some of the other established sodium channel drugs. It may work on peripheral nerves better than central nervous system for sodium. It's had at least one small phase 2 study that's been published a couple of years ago, suggesting that it may be effective in trigeminal neuralgia. The phase 3 study has been in limbo, partially because of ethical concerns about study design by the FDA, and probably some other reasons as well. We're hoping that this drug that the phase 3 trial starts by 2020. We've been waiting for that trial to start for about 2 years now. But what's really exciting about it is that if it works, it will be the second drug ever that will come out with an indication for trigeminal neuralgia pain. And then in terms of other new things, obviously every time a new seizure drug comes out, some of us will ask the question, does it make any sense that this might work, and we may try it in some patients. Again, we're using virtually everything in trigeminal neuralgia off-label, right? So is that okay to do? The answer is it is okay to do, but you should have a good reason for it. So when the FDA says, okay, we're going to approve drug number 6, whatever it's called, and the indication is for epilepsy, well, certainly we can use it for that, but sort of any doctor can prescribe any drug for any condition if there's at least some reason to use it, or at least some small study out there that suggests
they can provide any drug that's approved for human use for any condition.
That's a correct statement. Yeah.
No horse drugs.
No horse drugs.
These are all pills. Are there any medicines that you could take for trigeminal neuropathic pain that aren't pills?
Yeah, there are. Let me make a side trip before we get into some of that and say that there's not a lot of published data, but there's certainly a lot of anecdotal information, and it's kind of a quote, one of those things that every neurologist seems to know. But let's say you've got the most severe acute attack of trigeminal neuralgia in your life. I mean, you are at wit's end. You can give another anti-seizure drug called phenytoin or Dilantin through the IV. And there's a great chance, not a good chance, a great chance that you will have immediate relief that may last up to 48 hours. Not a long-lasting treatment, but it's really dramatic. If anybody in the audience has been through that, and I've certainly administered and seen, someone comes into the ED and they are severe pain. They are screaming. They are the loudest person there, and within 20 minutes of administering this, they get up and they could talk and touch their face and virtually be normal.
How do you get delivered? Can you do it in your office? Do they have to? Can they do it at home? How do they get this Dilantin?
Yeah, well, the Dilantin is IV. So, I mean, although some drugs are now, for other diseases are now done by nurses at home and so on, this is not really one of them. So this would have to be done either in an ED, an acute stay, an emergency center with monitoring, which would probably be an EKG. Some doctors' offices are set up with these kinds of things and have nurses on staff that could possibly do it, but most people are getting this either in an emergency center or an ED. But this is an important, treatment. Again, not a long-term thing, but sort of a get out of pain jail treatment that really works.
Nothing works. One can go to an emergency room under the guidance of a knowledgeable neurologist, a neurosurgeon, or pain management doctor, maybe, and get an infusion of how much Dilantin over how long, and why do they need to monitor?
Right. So because not every ED doctor knows this, what I recommend and what I used to do is write either on an office paper, or I guess we don't even write prescriptions by paper anymore, but I would write and give the patient, write down, my patient has trigeminal neuralgia. If he or she comes to the emergency room, give her Dilantin through the IV, and I would make some recommendations on dose. And EDs will know how to use the drug because they use it for seizure control. So I any doubt that they can handle the drug. They may not think of it. So I give our patients the instructions so that they can, obviously they can't talk most of the time. So this way they can show why I'm here. And that often worked. So I think that's a good thing. You can ask your doctor for that on a routine visit to give you that. So for a severe acute attack, I think that's something pretty good. There's another form of Dilantin called phosphenitoin. Again, a different molecule, similar but different, maybe a little bit safer. So by this point, that's also generic, and a lot of hospitals will carry that as well. It's a reasonable alternative. Now you asked about other kinds of medications that are not necessarily pills, and so people will look for patches or ointments and things like that. And so lidocaine, which is a drug that has many uses, could be IV, but also can be used topically on the skin, can be put on the face. And there's an often quoted study out of Japan from about 10 years ago where an 8% solution applied to the face where it hurts, again, can give some relief. The only problem with that is that there is no commercially available 8% in the United States, but you can go to a compounding pharmacy. And what's a compounding pharmacy? Compounding pharmacy has a special license. Most of them don't put big signs on the window, but you can look them up to find out if your pharmacist has a compounding license, and they can take existing drugs and do different things with them. They could, make a more concentrated solution of whatever. They can. People have tried things like taking drugs like Tegretol and some of the other anti-seizure drugs, crushing it and putting it into some sort of ointment or whatever where they apply on the face. Not sure how well those really work. I've run into patients that have tried that over the years. That can be helpful. Lidocaine also can be used intranasally. Again, the 8% solution can be very helpful for that. Again, has to be made by a compounding pharmacist, but we've tried that in a number of patients. And again, that's usually good for temporary relief on top of whatever existing baseline medication the person is taking. So there are a number of other things. And again, the good news, there are many things. The not so good news is that if all of these worked, then we probably wouldn't be having this webinar right now.
Pain management doctors sometimes advertise that they're ketamine infusion centers. Do you have an opinion about that?
Well, I mean, ketamine.
Use it, and how do you use it if you want to?
Yeah. I mean, there is some reason to think that ketamine can be useful. It's a drug that still is used, obviously, in the OR during surgeries as an adjunct in anesthesia. It does have psychogenic properties. Some people it can induce hallucinations in certain people and so on. So a little bit of caution on that. Not something
crazy for the rest of your life or what?
No. But while the drug is in your system, but again, I'm not saying that it should never be used. It's not. I wouldn't put it up there high on the list of acute medications to use on a routine basis. I would shy away. I shy away from anything that says it can work for anything. Right? It's unlikely that one medication, whether it's for pain or whether it's for something else, it may work on more than one condition. But when people start talking about something working in virtually any kind of medical condition, it's unlikely.
How many opinion about these centers that say we'll infuse it for 4 hours in our office?
My opinion is I would not recommend that.
We need to get into creams. What was the creams again that you like? Lidocaine? Anything else?
Well, I think also, some people have tried capsaicin, which is a different kind of drug found in some hot peppers. On the one hand, it can help. On the other hand, it can also be temporarily irritating before the pain relief kicks in. So some people have tried that as well. Again, when we're at the point of talking about these kinds of things, realize that we're really low down on things that are super effective or are mainstay. So maybe as adjuncts, but probably not going to be effective on their own.
All right, here we go. Marijuana, cannabinol. What about it?
What about it? Right. So obviously, we're in an era right now where a number of states are changing the rules of what you can or you can't use. It's a very politically charged molecule. Obviously, it's been around for a very, very long time. It's not coming to medical treatment the typical way that medicines come to medical treatment. You wouldn't, if somebody discovered the next Tegretol, they wouldn't be opening up Tegretol dispensaries around the country and having places that look a little bit like Apple stores with very friendly people saying, well, try this form in a pill, try this one in a brownie, try this one by smoking it, and so on and so forth. So there's that whole aspect of it that's probably not really the right way for things to go. But there are some legitimate reasons to think that there may be some use to it. We've seen in the last couple of years the development of a pill that has gone through normal channels of FDA approval and is the first really approved medical treatment for any medical condition, again, severe pediatric epilepsy. It's not the same drug as what you would buy and smoke marijuana on the street. Okay, so there are probably two main molecules in marijuana: CBD, cannabidiol, and THC. THC is the one that tends to cause the high. Cannabidiol does not cause a high, and maybe maybe the molecule that really is the one that seems to affect medical conditions in a positive way. So this drug that's now a medical marijuana drug that you can buy by prescription for epilepsy is really a CBD drug. So it does not induce a high, and it seems to work for these severe pediatric epilepsies. No, there's no data that I know about if it's used yet in trigeminal neuralgia. I'm going to bet that somebody somewhere has given it to a patient for that reason. But then it's kind of tough to do. There's a lot of regulation to it. I think that it's very hard. We've had patients that have gone to states where it's legal to purchase these products. And certainly the person behind the counter has no experience of any sort other than very anecdotal about how people are supposed to be using it, what form, how much, what dose. Just you're flying by the seat of your pants. I've had patients come back and say, well, I bought this in this state, and the person behind the counter told me to come to you to tell me how to use it. And although I'm a pretty smart guy, we don't really have a lot of experience with these things, so we don't really know. The other thing that is of some concern is that the production of these different legal medical marijuana products, and sometimes in certain states they are recreational marijuana products, it's not as well controlled. So what you buy 1 month may be different. You may think you're using the same amount by either milligrams or how much is smoked in 1 month, and then you go back to the same place with the same person and they're selling you the same product, but it may be a different dose. So it makes it very complicated in terms of knowing what's the right dose, what's the right thing. What do I look out for in terms of side effects? And again, I hate to say it, but some of this is reminding me of what we went through with opioids 25 years ago, when well-meaning physicians made decisions on some small studies and then declared that this thing was safe and okay to use in virtually everything, and that we were under treating pain. I think hopefully it will not end up being like that in another 20 years. But people do have side effects from these drugs, and people do end up in emergency rooms occasionally with psychosis and other mental status changes and so on. So the message is one of caution. The message is not that something won't emerge from this. And I know nobody on this webinar can wait maybe another 10 years. Real studies to look at this. So extreme caution. It's hard to recommend this. On the other hand, nobody's going to say that there isn't some patient somewhere where this might have helped for some time. So a very, very emotionally, politically charged issue, one that's not very well regulated, one that seems to be driven by economics and politics, a little bit getting ahead of the medical science. Hopefully there will be some work coming out in the next several years, not just in pain, but other aspects where different forms of medical marijuana may be of help, and we hope so. But I don't know if I can come out and say, hey, this is going to work for you. And I'm not sure that I'm confident that I can tell you exactly how much. Now, there are some physicians that say that they are experts in the use, and they're very knowledgeable in medical marijuana. Again, I suspect that their knowledge is not as thorough and certainly not very extensive for trigeminal neuralgia. Maybe they've given it to a handful of patients, and if they don't come back, how do you know if it worked or it didn't work? And maybe one or two that it did work comes back. It's just very anecdotal. It's just very hard to know what's right and what's wrong right now. So I hope that helps a little bit.
Let me switch gears a little and tell you a story. Let's say a patient, a young woman, a woman who's now, say, 50 years old, who 6 years before had a sudden severe attack of pain in her face, went to the dentist, said, I don't know what it is, or didn't go to the dentist till the next day. He doesn't see anything. But she wound up seeing a neurologist who said, hey, you have stabbing pain in your face. The dentist doesn't see anything. I'm giving you some medicine when the pain comes back. But the pain doesn't come back for like 6 months, so she doesn't take the medicine. And then when it comes back, she starts the medicine. Maybe she's taking a little bit of gabapentin. And she does that for a year or two, and then she gets another attack that's really severe. And she goes back to the neurologist, and he adds some baclofen. And that she does okay. And it's now 7 years later, and she's getting more attacks, more frequent, and she's back in your office. And now she's taking gabapentin, Tegretol, and baclofen, and she's back in your office. What next?
Yeah, unfortunately, a typical story, right, Jeff? I think, and the 7 years is important too. But I think that when you start using that much medication, and although it's doing something, it's not really getting rid of it. I think then you start to think about some of the really wonderful, more established surgical interventions for trigeminal neuralgia.
Put that in there as the neurosurgeon asking the question. There is a point
I knew you would.
where a neurologist has to say, you know, we really better get some help here. The medicine isn't enough. There is such a point. And
well, I agree with you, and I'm probably one of the ones that reaches that decision earlier than a lot of my colleagues. And why is that? Because I mean, and again, I'm not going to tell your story, but I mean, you will, you know, people like you who have been doing this for a long time with extensive experience with things like microvascular decompression and some of the other techniques, you're really skilled at it, and it's really dramatic how they wake up and they don't really have pain, and they don't need to take all this medication, and the quality of their life really goes up, and they do really, really well for the long term. So, you know, my job, you know, is to help make the diagnosis, make sure that there isn't something else causing it, you know, like a tumor or something unusual. Be the first line to make the right choices of medication, the right doses for the right person, make sure they're safe. But I don't wait 7 years, you know, to recommend it. I mean, if we're struggling with one medicine after another, and you can struggle because either it doesn't work, or you can struggle because, unfortunately, some people can't even tolerate low doses of the typical medications. If you're one of those, you're going to be thinking about a more definitive treatment. And again, these are great treatments. They're not just good, they're great treatments. And they have long-term effects in terms of reducing pain. And many times you're off medication, or if you're still on it, you're on a very low dose. So I've been convinced about this for a long time, that that's something that people should not have to go through years and years and years of pain to convince themselves that they need to do something surgically.
not even not to do something surgical, but the neurologist, presumably, who's taking care of this, would also want to be aware of making the diagnosis, doing the proper studies to see what's causing this pain, not just giving medicine. So the patients will want to make sure that they're being evaluated as well as treated. That's.
I agree. And again, I think awareness is better than it was 25, 30 years ago. Still, there are still, unfortunately, neurologists, and I'll bet there are people on the line that have experienced this, that either miss the diagnosis, or all they know is, well, I learned somewhere that Tegretol does it, and they give Tegretol and they can do that, but after that, they don't know what to do, and that's an unfortunate situation. So, you know, using the Facial Pain Organization to find the right professional is a great thing to do. You will do a lot less suffering. Working with the support groups that we have here, people in the support groups are incredibly knowledgeable, and sort of just calling and asking for help, you know, is so important, rather than thinking things like, oh, I have to take these pills, oh, I have to feel crummy on these pills all the time. You shouldn't wait very long. You know, you'll know pretty quickly whether or not you're going to respond or not.
Allie, do we have some questions that you've been submitted that you asked Dr. Cohen?
So Dr. Cohen, you mentioned a lot of different medications, but you did not mention Botox. What are your thoughts on that?
Well, there are actually, they're right. So, just because like we could probably go on for the next 3 hours if I went through every medication, but that's a great question. So there are some data on Botox injections. There is a at least one controlled trial out there that it can work to reduce pain. It's relatively safe medication. Again, probably not the final answer, the long-term solution. But I think it's a reasonable choice for certain people.
And the other medications that you mentioned, none of these are like, one is for atypical, one is for typical. These are all different medications to treat facial pain.
Yeah. So, I mean, that the bigger question I think is, do I treat, I've got atypical facial pain. What do I do? You've been talking about trigeminal neuralgia. We talk about trigeminal neuralgia because as few studies as there are, at least there are studies for it, for the trigeminal neuralgias that have that long-term chronic component where it never goes away, or for some of the atypical facial pains, whatever. You're probably still using a lot of the same medications. It's worth trying. The sad part is the efficacy or the effectiveness of the medications in those atypical conditions is not as good. Doesn't mean they never work, but they're not as good. I think the key is
we're going to confuse people at the very end by throwing in all these typical, atypical things. We're talking about trigeminal neuropathic pain, whether it's stabbing and nothing else, or stabbing and burning, or burning more than stabbing. Those are all trigeminal neuropathic pain syndromes. And it gets confusing when you start saying, is it typical? Is it atypical? Is it classical? They're all part of this basket, which can be a mixed basket with predominance of stabbing or predominance of burning, but you can use any of these medicines to treat those conditions, correct?
Agree with you. Yep.
Without confusing people, any more questions there, Ali?
Are there like any advantages over using like a chewable tablet versus a pill versus a topical?
Yeah, good question. So, and let me add to that also that a lot of these drugs now have a standard form and an extended release form. So an extended release form meaning that I can buy Tegretol that will remain in the system much longer. So again, something that I like to individualize. I'm someone that has an acute attack. A standard form of a drug will get into the blood system. A pill, the standard form of the pill, will get in the blood system faster than an extended release. It will give me, within an hour, it will give me what we call a peak level. So within an hour, that tells me if my pain is better with a standard release in an hour, I know that's a peak effect, and that I need that faster jolt of that medicine. If you can take the same medicine and put it into an extended release, and it will reduce that peak level at an hour. It doesn't get that high, but a lower level will remain in the system for a long time. So I listen to a person's pain history. I listen to, are they someone that has more than 50% of the time some sort of, standard burning long-term component? Maybe an extended release might be a better drug for that person. If it's something that needs to be treated fairly quickly and goes away, then maybe the peak dose effect or the standard form, which gets into the system faster, creates a higher peak amount. So I don't say that one is necessarily better than the other. I have to listen to the patient's pain history to make that decision. But most of these drugs now have a standard release and an extended release. So that's a good thing to have lots of options. I think, sometimes, again, we talked a little bit about, when do you combine meds? So, again, a little bit of personal experience on the part of the doctor from listening to their patients, because we don't have a lot of studies. But you know, if you're on Tegretol and then you want to supplement that with a patch or a nasal spray or whatever, we have a lot of patients in which that happens, and it works pretty well. I find patients are very smart and listen, those who listen to their bodies. If they can tell me that, then I can figure out, you know, what combination is probably a better one for them.
So we've been focusing for the past hour on medical treatment of trigeminal neuropathic pain, but I want to make sure that everyone keeps in mind that while we're treating this pain conservatively, that word has a little bit of trouble with it now, but anyhow, it's important that one also find out what's causing this pain, understand that there are all alternatives, there are surgical treatments, and at some point you may want to consider that the medicine isn't doing it for you, especially if it's causing all these complications. You may need to change medicine or move to another modality of treatment, but certainly you need to keep in mind what's causing the pain. Is there something else that can be done when the medicine doesn't work? And that's the topic of other webinars that we've done, which I invite you all to take a look at. We keep them on our website. And please come visit us in November in San Diego. If you have more questions and you want to interact with physicians, there will be experts there for a whole weekend at your disposal, and we will have lectures, and we will have time to sit down and meet with them. So I also invite you to support the Facial Pain Organization, which is providing you this webinar, and I hope you'll join as a member, and I hope to meet you all in San Diego in November. Thank you very much.
Thank you for having me, Dr. Brown.